All right, the next paper is a rapid-fire presentation, preliminary results of utilizing Cine angiography as an alternative modality during visceral vessel cannulation to reduce radiation exposure during BEVAR.
Thank you for the opportunity to present. These are our disclosures. So digital subtraction angiography, or DSA, is kind of our primary imaging modality that we use in most endovascular procedures, both peripheral and aortic. It has the benefit of adjusting the energy output to remove other radioopaque structures, which provides the best visualization for vessels. Overall radiation dose during DSA runs are usually about 50 to 100 times the normal fluoroscopy radiation dose. But on the other hand, Cine angiography is something that's often used in cardiology because it can compensate for some of the motion artifact of the heart. And has a higher frame rate and overall lower energy output. So radiation doses are usually about 10 to 50 times the normal fluoroscopy dose. We elected to try selectively utilizing this alternative mode during the visceral vessel cannulation steps in our fenestrated and branched endovascular repairs. So we actually did a total of 75 of these fenestrated branched EVARs at a single institution over a span of about 24 months. 68 were with DSA and 7 were exclusively using Cine mode during the visceral vessel steps. Switch to that using Cine mode was kind of attempted towards the latter part of our those 24 months. In some of those cases, the DSA only cases, the Cine mode was actually attempted initially, but if there was poor visibility or any big issues, we switched to DSA. And all of these were performed in our hybrid operating room in a very similar fashion with arms up. Shown here is also just an example of kind of the visibility in certain cases with Cine mode versus DSA. We analyzed the radiation doses, fluoro time, contrast use, and some of the patient demographics. So a similar case length was seen between the DSA and Cine groups. There was a significant reduction in overall radiation as measured by the dose area product and the air karma. With similar fluoroscopy times. And then when comparing demographics, the average BMI in the Cine mode patients was found to be significantly lower, 23.1 compared to the 27.9 in the DSA only. And here are just a few of our extended results. Again, this is a very preliminary data set, but it does serve to highlight a little bit that overall these were complex cases, many of which were 3 to 4 vessel fenestrations or branches, and many of which were also extent 2 and 4 thoracoabdominal aneurysms. So overall, Cine mode was found to reduce our radiation dose in some patients with lower BMIs, but in patients with kind of a larger body habitus, DSA may still be required to achieve that optimal visualization. We obviously still need to collect some more data. Our sample size was limited in this preliminary set, and that'll help us better determine which factors are significant. Yeah, I can take some questions now.
I think you kind of alluded to this, but how many times did you find that the Cine was inadequate and then you had to move to DSA afterwards?
Yeah, I don't think I have the number fully tracked, but from what we've seen is usually, again, in the patients with very high body habit, very large BMI and high, big body habitus, but I don't have a number.
And then any incidences on the post-op scans of those patients where you found like a subtle dissection in the renal artery that you didn't notice or something? That's always what worries me about not doing the subtraction.
Not that we had seen, at least. And that's something that we actually haven't, we didn't formally track that, but we hadn't seen that, at least in our set.
Thank you, Misty Humphreys from UC Davis, and Dr. Donde did a great job. It's hard to follow the UPMC group with Nathan and everything, but the truth is we don't have a fancy hybrid room that has digital zoom. We're still back in the Stone Ages, and for us, this was the one thing we could kind of do aside from moving the arms. The arms up really does make a huge difference, But for us, we really couldn't. I would love, I'm building a new room in this next year, but that's a big undertaking and it really is hard. We just built a new room in our cath lab and they put all the plugs on the top of the wall so nobody can plug anything in. And I don't know if maybe they turned the plans upside down in the middle of it, but it's amazing the little things that can happen as you're doing this stuff. And so it's something that we're doing now, just if you don't have the ability to do some of the fancier modalities.
Yeah, I totally agree. I think this was a great presentation, and I do think that, just like Misty said, everything is really dependent on what you've got, right? I mean, you got to use what you have. But I think the bottom line between all of these talks is that you really have to use what you've got to try to limit the dose. We can't just be doing cases at 5, 6, 7 grays anymore. You have to do whatever you can to try to limit the dose, and I think that's certainly a good message from this talk. That was a nice presentation.
Thank you.
Just one additional comment on that. We went through similar evolutions over the last years. New room, new setup, dealt with all the technical issues of that, changed our techniques. One of the key things that I think anybody can do is bring in your radiation safety officer. Every hospital, in my experience, has a life dosimeter somewhere. Put that on yourself and your trainee, wherever you're standing, and figure out what of your actual doing, your technique, incurs the most radiation. And then be cognizant of it and change it. I did that. It was eye-opening for me, and it really changed where I stand, how I work, what I do during the cases. I think that was probably the most educational and reduced the radiation the most for me.
Thank you. Yeah, we actually have tried doing something very similar at UC Davis as well. We've kind of tried to revamp a lot of our radiation safety, and this is one of the things that was part of it, getting all of our operators or trainees, everyone, to wear the dosimeter badge more reliably and have these doses actually tracked.
Thanks.
Thank you.